All right, another week. What a crazy week. Well, another question from one of the members from the Thriving Urology Practice Facebook group, where we are going to discuss what you can and cannot bill with a cystoscopy, a procedure that is commonly performed in the urologist's office. So we're going to talk about CPT, modifiers, and evaluation and management, and how to code for a simple cystoscopy, which is a great question brought up by Amanda, which I will read in just a second. For those of you who don't know me, my name is John Lin. I'm a urologist in Gilbert, Arizona at Sunrise Urology, also the humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. If you are watching this on the live stream, feel free to leave any comments below, and I will try to answer them as we go along. If you're watching this on a replay, I would appreciate any comments as well, and certainly give us a like, a thumbs up, and if you feel so inclined, subscribe to the channel. I talk a lot about medical practice management, coding, billing, and urology, and product reviews, and whatever comes to mind. All right, let's get started here. This question came from Amanda, who asked today, just 3 hours ago, how do your urology practices handle the billing for cystoscopies in your office? Currently, we bill as follows. So first scenario, if a cystoscopy is done in the office and the results are normal, say you don't find anything unusual, she writes, we do not bill for the office visit since we cannot justify it since it's included in the cysto CPT. Is this accurate? Well, I think that's a great question. I think some of the best coders, billers, and office managers are the ones who are really inquisitive. They don't just trust some dogma, and they are constantly pushing back and wondering, am I doing things correctly? Am I doing things in the most efficient way possible? Same thing for urologists. I think we all need to be inquisitive in our everyday dealings, no matter what we do. So her question about cystoscopy is, in essence, is a normal cystoscopy, say for UTI or hematuria workup, surveillance for bladder cancer, history of bladder cancer, etc. Say the results come back normal. Can you bill an evaluation and management if you don't do anything other than a cystoscopy? Well, her assertion in that if a cystoscopy is done in the office is normal, she doesn't bill an office visit because she can't justify it because it's included in the cysto CPT. That would be correct. A part of the, well, I think we need to understand what is included in the surgical package of a cystoscopy. Now, cystoscopy is a 0-day global procedure, 0-day global CPT. And you can just open up any CPT manual. You'll be able to see global, and it'll tell you what is the global days. Is it 0, 10, 90, or maybe XXX? So you need to understand what is the global for that particular procedure. It's 0 days for cystoscopy, all right, 0 days. And global, you need to understand what is included in that 0-day, 10-day, 90-day global. And let's go into, let's see, what is the Medicare definition? Now, this is Medicare. So it's not for all the private payers, but this is Medicare. And in essence, private payers follow Medicare's guidelines. So let's look at what's included in the global. This is according to Medical Learning Network booklet published in 2018. And in it, this is on page 6. Right here it says, what services are included in the global surgery payment? And I'll read this to you. Medicare includes the following services in the global surgery payment when provided in addition to the surgery. Preoperative visits after the decision is made to operate. For major surgeries, this includes preoperative visits the day before the day of the surgery. For minor procedures, which would include 0, 10, and these procedures that we're talking about for cystoscopies, for minor procedures, this includes preoperative visits the day of the surgery. It includes intraoperative services that are normally a usual and necessary part of a surgical procedure, all additional medical or surgical services required of the surgeon during the postoperative period of the surgery because of complications, which do not require additional trips to the operating room, because there is a modifier that you can use for that unexpected return to the operating room. But we're not going to cover that today. Follow-up visits during the postoperative period of the surgery that are related to recovery from the surgery. Now, that's also included. Post-surgical pain management by the surgeon is also included in the global package. Supplies, except for those identified as exclusions, is also included. Miscellaneous services such as dressing changes, local incision care, removal of operative pack, removal of cutaneous sutures and staples, lines, wires, tubes, drains, casts, and splints. Importantly for urologists. Insertion, irrigation, and removal of urinary catheters. That's correct. That's also bundled in the global package for that surgery. Routine peripheral IV lines, nasal gastric and rectal tubes, and changes and removal of tracheostomy tubes. Those are all included in the global surgery payment. So when Amanda asks, is there some CPT, is there some office visit evaluation management that's included in the cystoscopy CPT? And the answer will be yes. The stuff that you need to do to get the patient ready, to make sure the patient's safe to undergo that procedure, make sure, for instance, he or she doesn't have a active urinary tract infection, making sure that if you plan to do, any sort of biopsy, that maybe they're off of blood thinners, making sure that patient has adequate sedation if the patient's super anxious, and making sure the vitals are okay, making sure that the patient knows what to do afterwards. The preoperative evaluation, making sure the patient is mentally with it to consent for the procedure. Those are things that you do before the procedure. That's included in the global package of cystoscopy. And as you just heard, what is also included in cystoscopy is everything that you need to perform the procedure. For instance, the drapes, the irrigation, the tubing, the cystoscope, the cleaning of the cystoscope, and any sheaths, cystos sheaths, if you're using that particular system where it requires a sheath. That is all included. What about afterwards? Making sure the patient's okay, making sure that she tolerated the procedure okay, making sure that she is comfortable, making sure that she's not dizzy, anxious, discussing with her what was found on cystoscopy. Guess what? All that is included in the generous payment. Yeah, I say jokingly, in the generous payment for that CPT for cystoscopy. So she is correct. There is a component of evaluation and management that is included in the CPT for 52000 cystourethropy. So let's go on to the next part of her question. All right. If a cysto is done in the office and say something abnormal is found and surgery is discussed, then we can bill with an office visit with the cysto. So that's her scenario number 2. So this is not uncommon. For instance, you see the patient initially for gross hematuria, you schedule the patient for subsequent cystoscopy, you perform cystoscopy, and you find a tumor within the bladder. So bladder tumor. And then you talk to the patient. Well, what is that? You sit down with the patient after the cystoscopy, you talk about the findings, the implications, the treatment options, and they finally decide on a course of treatment. So as I already mentioned, what's included in cystoscopy is telling the patient what you found. What is not included is, what does that mean? What are the treatment options? And what are you ultimately going to do about it? And what do you, as a urologist, recommend? What does your practice recommend? So knowing what is included in the global package and what is not is really, really important if you want to bill an evaluation and management on top of a CPT, like a cystoscopy that you do in the office. Now, this requires a modifier 25. And I will also include, I'll probably include in the show notes or at the end of this video, a video that I did about modifier 25. I think I did at least 3-4 videos at least about Modifier 25. It is one of the most scrutinized modifiers by CMS, by Office of Inspector General, because it is, a lot of people misuse it, either intentionally or unintentionally, and it is under the Office of Inspector General's work plan. It has been on their work plan for years because it is often misused and abused. So if you use Modifier 25, be ready for audits. Be ready for chart pulls and chart requests. And you want to make sure that you're using it correctly, because audits are not when. It's not a matter of if, it's a matter of when. So if you're going to use Modifier 25, make sure you're using it correctly. In this situation, you perform a cystoscopy, you find something abnormal, and you sit the patient down. You talk to the patient. You come up with a game plan, like say surgery to remove the bladder tumor. That is a separate thing or service that you did, which is significant. And here's the other thing that's required for Modifier 25, is it separately identifiable, significant and separately identifiable. So Modifier 25 is used on the E&M CPT, on the E&M code, and not on the CPT. You append Modifier 25 on the E&M and not the CPT. In this situation, when you do a cystoscopy, you find something abnormal, you talk to the patient about what it means, what you plan to do, and ultimately decide on a surgery, that is a significant service that you provided. But to satisfy Modifier 25 criteria, it also has to be separately identifiable. So in your mind, there is clearly medical necessity for Modifier 25. But how do you make it separately identifiable? How do you make that layman, coder, biller, auditor look at that chart, look at your note, and see that this clearly is separately identifiable? Well, ideally, the op note, the procedure note for your cystoscopy, hopefully is in a separate section of your EMR. And then you go through the discussion in a separate area of your EHR. For instance, the assessment and plan. It could be bladder tumor. And then you talk about findings, implications, treatment options, and ultimate decision to undergo surgery. That is all documented in that separate area. So significant from a medical perspective, from a work effort perspective, and also separately identifiable in a documentation perspective. If you can reach both of those goals when you bill a Modifier 25, you're going to be safe. You're virtually going to be audit-proof unless your documentation is so poor. So if a cysto is done in the office, it's abnormal, you schedule surgery, it doesn't mean that it's automatically Modifier 25. You need to provide the documentation to satisfy significant and separately identifiable. Okay? I won't belabor Modifier 25 definition because I've done it so many times, and I'll include it in I'll include a video that I talk about, multiple videos. I'll include that at the very end. So hopefully you understand. And if you want me to go over the definition of Modifier 25, I'm happy to do that again. So here's the number three things. Number three, the third point. She asked, thoughts are to do the cysto one day and then have the patients come back a few days later, either in person or via telemedicine. So I will tell you, if I were a patient and there's something abnormal on my cysto, I certainly don't want to leave and then come back, and especially if it's bladder tumor that you suspect it's bladder cancer. So I certainly don't want to come back another day. I want you to talk about it. I want you to address it today. To send the patients away and then to have the patient come back just so that you can bill a separate E&M, that is bad for you, bad for the patient, and it's just bad for business in general. It is just bad practice. I do understand that you can't perform a CPT service to the patient, to a Medicare patient, purely for patient convenience. We know about that. In this case, you're not doing it for patient convenience. You're doing it out of medical necessity. So you can see the patient perform the cystoscopy, find the abnormality, discuss with the patient what to do, schedule surgery, and bill for that evaluation and management service, provided that you perform and provide adequate documentation. Because medically, yes, there's medical necessity to perform the evaluation and management. You found a tumor, and it is separately identifiable. You can separately identify the documentation in your EHR because you have a cysto note and you have your assessment and plan talking about the finding of a tumor in the bladder or some abnormality in the bladder. It doesn't even have to be a bladder tumor. And a common misconception, and we're going to go into comments here in a second, common misconception is that you need a separate diagnosis. You do not need a separate diagnosis for a Modifier 25 visit. Jonathan said, whether the cystoscopy findings are normal, this is in the comments of the post, whether the cystoscopy findings are normal or abnormal is irrelevant. You can bill for an office visit in addition to the cystoscopy if you provide a separately identifiable service that meets Modifier 25 criteria. I could not agree more. Okay. For example, I've performed cystoscopy on many overactive bladder patients or patients with incontinence, and oftentimes the cysto findings are completely normal. I have a separate conversation with them about further evaluation and management and discussion of their disease process, discuss physical therapy, prescribe overactive bladder medication, or discuss neuromodulation or Botox or sling surgery. This would be a separately identifiable discussion that would justify an evaluation and management service code. Clearly, this doctor understands what is required of a Modifier 25. That is beautiful. You provided a cystoscopy, and in this case, the diagnosis is the same. Overactive bladder. That is the reason for cystoscopy. And then afterwards, you talk about the benign findings, implications, treatment options, and then come up with a treatment plan. All separately identifiable from the cystoscopy, which turned out to be normal, using the same ICD-10, same diagnosis code of an overactive bladder. Beautiful, Jonathan. All right, Mimi, this is great. Mimi, what about an established patient? We're going off track a little bit, off tangent. What about an established patient that sees the nurse practitioner in the office who is doing follow-up based on the physician's last plan of care? Very good. That would qualify for incident 2, by the way. She performs a digital rectal examination, discusses medications, etc. The patient also scheduled for his biannual cystoscopy with the doctor on the same day. So this is not very clear to me. Did the patient schedule for cystoscopy to be done in the future? Which is how I'm reading this. And if this is part of the plan of care that was dictated by the urologist, by the physician, then if you are planning to bill incident 2, you'll be covered. However, if there's a change of plan of care from what was prescribed, say in a protocol by the urologist, then obviously the physician needs to be involved, the urologist needs to be involved in that visit that day, see the patient so that you can bill incident 2. If there's a change in the plan of care from the previously prescribed protocol, then no incident 2, meaning you would bill at the NP, at the nurse practitioner's, using the nurse practitioner's NPI at 85% of the full fee schedule. In addition, you need to be mindful that if this is, assuming this is Medicare, because private payer rules may differ, if this is Medicare, the patient, the urologist who is planning to bill incident 2 needs to be in the office working in a clinical capacity. Incident 2 rules are very tricky. You need to be absolutely certain that you're doing everything correctly, or else you're going to be subject to recoupment and fines and penalties from the government, CMS. Not a good idea. So make sure if you're going to bill incident 2 that you follow the letter to a T. All right, Mimi further says, I think because the NP is working incident to the doctor and he is in the office, assuming that he's performing clinical duties, the E&M visit can be billed with the doctor's ID with a 25 modifier as a 52000 for the CISO. Okay, so the scenario has changed. So that means the NP saw the patient, did a rectal examination, talk about medications, and then the physician does a pre-scheduled biannual cystoscopy. I'm assuming it's for bladder cancer. Assuming. I don't know. That's why when it comes to coding and billing, I need all the details, every single detail. And I'm also assuming this is Medicare. I'm assuming this is done in the office setting, right? So there are a lot of assumptions that I'm making. Assuming it's a Medicare patient, assuming this is being done in the office, assuming this is a private doctor's office, the NP sees the patient, does some DRE, talk about medications, and I'm assuming, again, that the NP simply continues the medication following the plan of care, and now the urologist performs a cystoscopy, pre-planned biannual cystoscopy. So assuming, again, that biannual cystoscopy is done for a separate diagnosis and reason than the DRE and medication therapy, I'm making a lot of assumptions. All right. Assuming that's the case and the physician, the urologist involved, then yes, you can, because the urologist is practicing, clearly working in a clinical capacity in the office that day, and the MP is simply following the rule, the plan of care by the urologist from a previous visit and not making any changes, and there are no new diagnoses that are being managed by the MP, then yes, you can bill for whatever the MP is seeing the patient for, which is different than the pre-planned cystoscopy. Again, I'm making assumptions here, assuming that these are two different diagnoses, okay? So Mimi said, let's see, am I thinking right above? So with my assumptions, hopefully I answered that question. And Jessica said, if the patient is booked for a cysto, unless they bring up a separate ailment, for example, surveillance cystoscopy for tumor history, and they want to discuss a vasectomy, which is totally different, then the office visit is warranted. Well, yes and no, Jessica. Yes and no, because again, Modifier 25 does not require a separate, different diagnosis. Modifier 25 you don't necessarily need, it's in the definition. Look it up. It's in the definition of Modifier 25. You do not need a separate diagnosis. Literally, it says that you don't need a separate ailment, separate diagnosis. So let's get back into it. There is an amount of E&M built into every procedure, so a visit when it's directly related to the cysto isn't usually prudent. And again, highly audited on the OIG's work plan every single year is the use of Modifier 25. So your comment here is right on the money. Unless it's medically necessary, unless it's significant, unless it's separately identifiable, you need to satisfy all three criteria: medical necessity, significant, separately identifiable, then, and you document it all, then you can use a Modifier 25 on the evaluation management code along with the CPT on the same day. Jessica said, I had a 3-day argument with one of my physicians about this very topic. Well, it doesn't have to be an argument. It's clear, and just have your doctor watch some of my videos. It's on YouTube, it's on Facebook. Have them join this Facebook group. For God's sake, it's free. Come on. All right. Craig says, Jessica, sounds like you won the argument and cost your practice thousands in revenue. Document. Virtually every cysto has a discussion about plans, medications which increase the level, different therapeutic options, etc. The only time I don't bill E&M is a negative hematuria workup. Again, Craig, it is not necessarily, yes, it sounds like you understand what I've been saying, that you need a separately identifiable service and discussion about plans, right? Treatment plans. Again, implications and treatment options. The finding of the cystoscopy is included in the global package for the CPT for cystoscopy, but the implications, treatment options, ultimate decision to start a medication, stop a medication, renew a medication, schedule surgery, those components are not part of the part of the CPT, part of the global for cystoscopy. And I think what you're saying here is you're indicating to me that you do understand the concept of Modifier 25. And Jessica said, Craig, I did win the argument, but office visits with procedures are reviewed for prudence because I don't believe in artificially inflating the accounts receivable, and I want them to be defensible in an audit. Brilliant. Very, very good. Very good points. And then she said, what is it that John Lynn says? Oh, yes. Just because you can doesn't mean you should. That's correct. Just because you can. And not only that, just because you can bill for it and just because you are paid for it doesn't mean you should do it. Medical necessity, you have to follow the CPT, the NC, the National Correct Coding Initiative, the NCCI guidelines. You need to follow all of that and code correctly and bill correctly. All right. I think that covers it all. And if this seems confusing, it took me a long time to figure this out. And I'm still constantly reading up on it because the changes happen pretty much all the time. If you look at the global surgery from MLN booklet from 2018, if you look here, what services are included in global surgery payment, right above that, for more information, refer to Medicare Claims Processing Manual, Chapter 12. And if you go to Chapter 12, under Section 40.1, definition of a global surgical package, it goes into much more detail about 0-day, 10-day, 90-day, what is included in a pre-op, what is included in the global service package, and what is not included in a global surgical package. So you can go really, really deep into it. And if you are still kind of unsure, if you still want more information about not just modifier 25, but all the other modifiers, 24, 57, 58, 59, XU, XE, there are resources available. And believe it or not, today is the last day for that early sign up, early bird registration for PRS Network's Urology Advanced Coding and Reimbursement Seminar. If you go to prs.com, you'll be able to find this website and also the link to register. There are 2 different sessions, one in December of this year, December 2nd and 3rd in Las Vegas at Bally's. It's a Friday and Saturday. I love how PRS is so respectful of our time so that we're not missing too much of clinic to attend this valuable course. And then January 27th to 28th in 2023 in New Orleans, Louisiana at Harrah's. It's always a good time. I had such a great time when I was in New Orleans in 2020, right before the pandemic fully hit. It was such a great time. So some of the topics that will be covered, and I'll be one of the presenters there. Mark Painter is going to give us an update on by then it'll be finalized, the 2023 Medicare physician fee schedule and all the changes to E&M, all the changes to the updates to the CPT, the conversion factor, and a bunch of other changes. Some of the concepts regarding global and global package will also be covered. The use of different modifiers, for instance, the complex modifier, modifier 22, modifier 25, 59, X modifiers. Those are all going to be discussed. Coding for new technology. If you're thinking about implementing some new technology in your office, some of these technologies will be discussed. And we will definitely discuss some of the things that you should consider before you say, sign me up. I will buy the $30,000 device and bring it into the office. There are a lot of things that you want to think about before you jump into that. And of course, urology billing and coding conundrums about PCNL, ureteroscopy, stone surgery, bladder stone surgery, bladder tumor, for instance, TURBTs. Something that is really hot right now is PCR, polymerase chain reaction, also known as molecular diagnostics. Those of you in LugBuzz know, or in small groups know, that things are really, really coming down when it comes to appropriately documenting and coding and medical necessity when it comes to PCRs, and also payment for PCRs is changing greatly. Robotic assisted surgeries, unlisted codes, and bundling for coding and billing will be covered. Very importantly, documentation. Everything is about documentation. And also the changes regarding evaluation and management in the rules change in 2021. For those of you who don't know this, the E&M rules change in 2021. And then we are definitely going to go over some actual scenarios regarding E&M 2021, where this will always spark a lot of discussion regarding what actually happens in your practice. And also the No Surprises Act. So those of you who are aware, something came into effect January 1st of 2022, and that is the No Surprises Act. No more surprise billing for those patients who, for instance, go to the hospital and have an emergency and they're hit with all these out-of-network bills. That is being tempered. As a matter of fact, I saw a patient today who was worried about a foot injury that he sustained, and he went to the hospital, and now he's dealing with $34,000 of bills that he received. And I told him about the No Surprises Act. Hopefully, he is now empowered so he can extract himself from the discussion, because the dispute now is between the hospital and the insurance company. We're going to also talk about telemedicine and also ICD-10. And those who should attend are urologists, whether you're employed or private practice, other qualified health professionals, APPs, advanced practice providers, nurse practitioners, physician's assistants, coders and billers, administrators, practice administrators. We even have someone who works for the insurance company who attended the course because he wanted to understand more about urology. If he's going to audit, if he's going to opine on urology coding, he wanted to know more. So he was one of the attendees, and he offered some really good insight regarding what to look for, what to expect. Dr. Painter will be there. I'll be there. Mark Painter will be there. Larry Kemp will be there. And of course, Scott Painter will also be there. And if you are interested in learning more about Modifier 25, I will, if you're watching this on YouTube, I will link, I will put that in this video over here, and another video regarding Modifier 25 and also Modifier 57, I'll put it in this card over here on the left. As usual, I thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.